Surgery and anaesthesia is necessary treatment in reducing disability and death amongst millions of people worldwide. Surgical procedures are significantly increasing in the nation of Australia as research and technology develops. This results in a large cohort of Australian recipients. For emergency surgery and procedures, the most common population groups include males, the elderly, low socio-economic groups, remote dwellers, and Aboriginal and Torres Strait Islanders. For elective surgery, females, the elderly, inner regional dwellers, and Aboriginal and Torres Strait Islanders are most common. Despite the benefits of surgery, potential harm does exist. This includes post-operative pain, which is a widespread healthcare issue that begins from the emergence of anaesthesia and can continue into the recovery and even post-recovery period. Post-operative pain impacts all surgical patients in varying degrees, with 50 to 70% of patients experiencing moderate to severe pain post-operatively. When poorly controlled, post-operative pain can cause post-operative complications and the development of chronic pain. It can also delay wound healing due to increased inflammation and prolonged hospital stay due to delayed ambulation and physiotherapy engagement, increasing the burden of disease. Poorly controlled post-operative pain can also lead to adverse effects associated with prolonged opioid use. For example, respiratory depression, drowsiness, bowel dysfunction, nausea, and vomiting. It can also increase the risk of developing deep vein thrombosis and pulmonary emboli due to prolonged immobilization. An effective pain assessment is essential in providing appropriate post-operative pain management. The gold standard is self-report, as pain is a subjective experience. However, this should be considered in conjunction with the behavioural manifestations of pain. Effective methods to allow for this include the numerical rating scale, which can be used to measure pain intensity and pain relief efficacy. The NRS uses a scale where 0 represents no pain or no relief, and 10 represents the worst conceivable pain or complete relief. Other methods include the verbal rating scale, which uses a scale of adjectives to describe pain, and the visual analog scale, which uses visual depictions to describe pain, as well as the PQRST tool, which is a holistic assessment assessing the precipitating event, quality, radiation, severity, and timing of pain. Pain assessment should be achieved as part of post-operative observations and should actively inform the patient's pain management plan. Evidence-based practice suggests that pain management must begin in the preoperative stage. This is where the patient is educated on treatment options, goals, and medications, and where the patient informs the multidisciplinary team of their history, previous treatment, and medical and psychiatric comorbidities. Multimodal analgesia is also the most supported form of post-operative pain management. This is where multiple medications are used that target different pain pathways to allow for a synergistic effect. Non-pharmacological interventions can also be utilized in this approach. Best practice evidence also demonstrates that it is essential for nurses and doctors to use clinical judgment and reasoning when prescribing and administering medications, as well as considering patient preference. Key assessments such as vital signs, fluid balance, and wound assessment must also be achieved to monitor post-operative pain and adverse effects of surgery or medications. There are many policies and procedures that exist to ensure best practice guidelines are implemented within the clinical setting. The perioperative toolkit ensures education of the patient and their family and carers, considering the standardized perioperative pathway. It also allows for a systematic approach in gathering information about patient health and history, ensures communication between the multidisciplinary team, and promotes quality improvement. The National Pain Strategy also encourages evidence-based practice. This is achieved through structured objectives which support patient education, education of healthcare professionals, access to interdisciplinary care, quality improvement, and ongoing research. In contrast, the Medication Handling in New South Wales Public Health Facilities Policy Directive solely focuses on the procurement, storage, prescribing, supplying, dispensing, and administration of medications. This includes specific guidelines for Schedule 8 medications and patient-controlled analgesia. This ensures for the quality use of medications and decreases medication errors that could contribute to poorly controlled postoperative pain. The Clinical Procedure Safety Policy Directive addresses patient checking, risk assessment, clinical care, and communication pathways, which decreases unnecessary postoperative pain and ensures optimum intraoperative care. Lastly, the eHealth Strategy for New South Wales Health 2016 to 2026 allows for greater and concurrent documentation and assessments, access to diagnostic results, medication management, and multidisciplinary and interdisciplinary communication. However, despite best practice recommendations, postoperative pain management still remains a prime concern for healthcare professionals. Postoperative handovers are often complicated and information dense. This can lead to information deficit, ineffective communication of the patient's pain management plan, and poor transfer of care. Resources can also often be unavailable, leading to adverse adjustments in the patient's care plan. For example, staff shortage can lead to ineffective assessment, and specialised pain personnel are often not available after hours. Education can also be a barrier, as patients are often unaware of the side effects of medications and their care plan, despite interview with anaesthetists and preoperative education. This can also be demonstrated amongst healthcare professionals who do not have specialised knowledge on analgesia and pain management. Pain management is also often biomedical heavy. This deprives patients of the many benefits of non-pharmacological pain management interventions. There are many strategies that can be utilised to combat these barriers. For example, having a standardised handover protocol has been proven to significantly improve postoperative communication. This can be achieved using a postoperative handover checklist or the SBAR handover format. Further education of healthcare professionals is also required to allow for timely and evidence-based practice. This can be achieved through increased access to and education from pain specialists in surgical wards, increased training opportunities, and pocket-sized summaries on pain assessment and management. Further education of patients is also recommended. This could include a preoperative pain management course that needs to be completed prior to admission, and education resources that are accessible to patients throughout the whole standardized perioperative pathway. Integration of biopsychosocial interventions is also recommended. Postoperative pain continues to be a major concern. However, best practice guidelines can be implemented effectively to address this issue.